The San Diego Musculoskeletal Project presents the Shoulder Physical Exam Part 2. This video is the second of a three-part series on the shoulder exam. Part 1 covered functional shoulder anatomy. Part 2 includes the first 4 steps of the shoulder exam: observation, palpation, range of motion, and strength testing. Finally, provocative tests will be covered in Part 3 of our shoulder exam series. The first step, as with any musculoskeletal exam, is inspection or observation. For the shoulder exam, we can observe both bony and muscular abnormalities. For instance, you might see old clavicular fractures or acromioclavicular separations. A high riding shoulder might be an indication of superior humeral migration, which can occur after rotator cuff rupture. Besides bony abnormalities, you can observe muscular shoulder abnormalities, including the Popeye sign after rupture of the long head of the biceps tendon, or rotator cuff atrophy, which can be subtle or more pronounced, especially with flexion against resistance. Severe rotator cuff atrophy can be seen in patients with long-standing rotator cuff ruptures. Overall, simple observation might give you clues to prior injuries and tendon ruptures that could affect the function and strength of your patient. After inspection, the next step in the shoulder exam is palpation. I usually palpate the bony landmarks from medial to lateral, starting from the sternoclavicular joint. Then I walk along the clavicle to the acromioclavicular joint, which has a palpable joint line under the tough AC ligament. From the AC joint, find the coracoid by palpating slightly inferior and medial. Tenderness at the coracoid may indicate pathology of the short head of the biceps or the coracobrachialis, which combine to form a conjoined tendon. From the coracoid, return to the AC joint and palpate laterally to find the acromion. Palpate both the lateral edge and the posterior edge of the acromion. Now palpate under the acromion to check for subacromial tenderness. Palpate the biceps tendon in the bicipital groove. Tenderness at this site is common and may indicate biceps tendinitis. And finally, palpate along the posterior scapular spine and the paths of supraspinatus, infraspinatus, and teres minor for tenderness. In this video, you see the physician following the medial to lateral palpation path. The order of palpation is up to you, but if you are consistent, you'll be less likely to overlook any palpation sites. From the AC joint, this physician moves to the acromion and the subacromial space. She then moves anteriorly for palpation of the coracoid and the biceps tendon, which you can see rolling under her fingers in the bicipital groove. She then moves to the posterior structures and palpates the posterior scapular spine, supraspinatus, infraspinatus, and teres minor. As demonstrated, a careful palpation exam can be completed in under a minute. After palpation, the next step in the shoulder exam is range of motion. Although the ball and socket shoulder joint has 360 degrees of motion, shoulder range of motion in the physical exam is measured in 4 different directions: forward flexion, abduction, external rotation, and internal rotation. Each direction can be tested first actively on the patient's own effort and then passively if there is any limitation, to differentiate between pain and a frozen shoulder. Forward flexion is accomplished by a number of muscles, including the biceps. Thus, forward flexion is painful for patients with biceps tendinitis or subacromial impingement, since forward flexion compresses the subacromial space. Supraspinatus function is isolated in early abduction, but the deltoid completes the higher arc. This motion is painful for patients with supraspinatus pathology or subacromial impingement. If the patient completes adduction slowly below 60 degrees, he will effectively perform the drop arm test, in which the affected arm drops down from supraspinatus weakness. External rotation isolates infraspinatus and teres minor function. Neutral position, or 0 degrees, is when the patient has his arms flexed at the elbow with hands straight ahead, as shown. External rotation is measured in the horizontal plane as the shoulder rotates the forearm laterally. External rotation on our healthy volunteer is almost 80 degrees. However, on this patient, external rotation is limited to 30 degrees on the right and 45 degrees on the left. Finally, internal rotation isolates subscapularis function. Internal rotation can be measured in different ways, but asking the patient to bring their thumb as high as possible on their back gives the advantage of quantifying internal rotation by spinous level. Our healthy volunteer can reach the bottom of his scapula, which is about T7. Note that the top of the scapula is usually about T2. However, our patient can barely internally rotate past L5S1 on the right and barely past T12 on the left. Now that we've completed range of motion testing for the shoulder, we can move on to strength testing. For the large muscles of the shoulder girdle, strength testing consists of resisted flexion and extension at the shoulder for anterior and posterior deltoid strength, then resisted flexion and extension at the elbow for biceps and triceps strength respectively. We'll talk more about shoulder abduction in the context of the rotator cuff strength exam, but shoulder abduction tests deltoid and supraspinatus strength, while adduction tests pectoralis major strength. After testing the strength of the large muscles, an important part of the shoulder strength exam is isolating and testing each rotator cuff muscle action. The sits mnemonic can give you an order for strength testing so that no rotator cuff muscles are overlooked. Most of these motions hopefully look familiar to you since we just reviewed range of motion. Shoulder strength testing simply consists of resisting each rotator cuff muscle during its range of motion arc. We'll start with supraspinatus. The supraspinatus strength test is also called the empty can test. Traditionally, the empty can test is done with patients resisting abduction with their shoulders at shoulder level, 30 degrees forward, and thumbs internally rotated downwards. Since we know supraspinatus assists in early abduction, the formal test probably has a significant contribution of deltoid strength. To focus more on supraspinatus strength, you can lower the resisted angle of abduction to 60 degrees or lower. Next, remember that infraspinatus and teres minor externally rotate the humerus. Thus, we simply test infraspinatus and teres minor strength by resisting external rotation. When you test external rotation, be sure that the patient's elbows remain at their side, and then resist external rotation at their distal forearm. Otherwise, patients may compensate for weakness by abducting their elbows away from the body. Finally, subscapularis is the internal rotator of the humerus. The extent of internal rotation was measured by the level of spinous process reached by the patient's thumb. Subscapularis strength is tested by the patient pushing away from his or her back against your resistance. This test is also called the Gerber liftoff test. This concludes part 2 of our shoulder exam series, in which we reviewed the inspection, palpation, range of motion, and strength components of the shoulder exam. A summary of each section of the shoulder exam can be seen here as it might be written in a note. The last part of the shoulder exam, the provocative tests, can be seen in the third and final part of our shoulder exam video series on the SdMskProject channel. This video was brought to you by the San Diego Musculoskeletal Project. Thank you for watching.